This eMultiple Sclerosis review program is presented by DKB Med Radio.
She had multiple lesions in both her brain and her spinal cord, suggesting she had very active and highly inflammatory disease. So we were keen on starting her on a high-efficacy disease-modifying therapy, or DMT. And this pattern really reflects how pediatric patients with MS tend to have greater inflammation and also disease activity in general early in disease relative to patients with adult onset MS.
POMS, a clinical view. Welcome to eMultiple Sclerosis Review. Pediatric Onset Multiple Sclerosis, POMS. How different are the presentations between pediatric and adult onset MS? How can clinicians avoid symptom mimickers to ensure diagnostic accuracy? When should pediatric patients be treated with high-efficacy disease-modifying therapies? Which DMT for which patient is likely to be the safest and most effective? What do the data show about POMS and family history? To answer these and other questions, we're joined today by two MS specialists from the Johns Hopkins University School of Medicine, where Dr. Haiwen Chen is an assistant professor of neurology, and Dr. Karla Gray-Roncal is a fellow in neuroimmunology and neurological infectious disease. For our guest disclosures and additional CME information, please go to our website, eMultipleSclerosisReview.org, and select the Volume 6, Issue 2 link. I'm Bob Busker, executive producer of DKB Med's e-literature review video programs. Dr. Chen, Dr. Gray-Roncal, thank you both for joining us today.
Thank you, Bob. We appreciate the invitation.
It's great to be here. Thank you.
Our overall learning objective for today's program is to discuss the evidence that informs treatment decisions for pediatric patients. Our first focus for that learning objective is to describe why early recognition and diagnosis of POMS can improve outcomes and why the initial evaluation should include assessment of cognitive and mood symptoms. So that being said, if you would please, Dr. Chen, start us out in the clinic with a patient scenario.
All right, thank you. So today I'm going to share with you one of our patients. She's a 17-year-old young woman. She actually initially presented with a headache attributed to migraines, but then one day she woke up and in addition to a headache, she had difficulty standing and walking, so ended up in the emergency room. In the ED, she had bilateral numbness from the waist down. She had difficulty initiating bladder and bowel movements, and she had blurry vision, particularly when looking left. When you ask her in hindsight, she actually had an episode of left leg numbness 3 or 4 years ago. Around that time, she also started having issues with school. And so at that time, she was in middle school and ultimately got set up with an individualized education plan, or IEP, to help her. She did get an MRI in the ED. It did show multifocal ovoid T2 flare white matter lesions that were scattered throughout the brain that were justacortical, periventricular, in both supra and infratentorial brain regions, as well as in her spinal cord. And some of the lesions were enhancing and some were not. Additionally, she actually had an enhancing left optic nerve lesion as well. And so she was admitted to the hospital due to concern for new onset demyelinating disease. She had a lumbar puncture, which ultimately showed mild lymphocytic predominant pleocytosis, positive oligoclonal bands, and an elevated IgG index. Due to the concern that she may have multiple sclerosis, we had also tested her for JC virus status, and she was JC virus negative. So ultimately, putting that all together, the MRI, the presentation, the CSF studies, she was ultimately diagnosed with pediatric onset MS. And after some discussions, we started her on natalizumab as a disease-modifying therapy.
Interesting. My first question, Dr. Gray-Roncal, do you agree with that diagnosis of pediatric onset MS, or POMS? And if you do agree, why? Break it down for us, if you would, please.
Yes, I do agree. For this patient in particular, She's got multiple clinical events that are consistent with MS flares. She had episodes in the past with numbness, and then more recently with her current presentation that also included optic nerve enhancement. So all this itself can fulfill criteria for dissemination in space and in time.
Take a moment to remind me of those space and time dissemination criteria, if you don't mind, Doctor.
Sure. So dissemination in space means lesions that are at least in two different regions of the brain. So this is when we talk about different regions such as juxtacortical, periventricular, infratentorial, or in the cord. And then dissemination in time means a new lesion from one MRI to the next, or the presence of enhancing and non-enhancing lesions in one single MRI. Or this criteria can also be fulfilled with positive oligoclonal bands in CSF.
And this patient showed both, yes?
This patient showed both. So because in this patient also her MRI showed that some lesions were enhancing and some were not, it was suggestive that these lesions were done at have different ages, fulfilling this criteria again of dissemination in time. And then also her CSF did show an inflammatory pattern, including the presence of oligoclonal bands, which is found in greater than 80% of patients with MS.
Natalizumab, why was that the DMT chosen for this patient, Dr. Chen?
Yeah, that's a great question. The reasons for that choice were pretty multifactorial. First, from a clinical standpoint, she clearly, from her MRI, already demonstrated a high lesion burden. She had multiple lesions in both her brain and her spinal cord, suggesting she had very active and highly inflammatory disease. So we were keen on starting her on a high-efficacy disease-modifying therapy, or DMT. And this pattern really reflects how pediatric patients with MS tend to have greater inflammation and also disease activity in general early in disease relative to patients with adult onset MS. Growing evidence now in the literature from larger populations of pediatric onset MS patients are showing that use of higher efficacy DMTs can improve prognosis in MS for these patients. And that means reduced number of relapses, reduced number of lesion accumulation on MRIs, as well as better long-term outcomes in terms of lower disability. We are overall pushing towards more higher efficacy DMTs over time. On a very practical level for this patient in particular, she actually had difficulty swallowing pills. So she really didn't feel comfortable with a daily pill that she would have to take, or multiple times a day even. And she also felt like she would likely forget to do it on a daily basis. And from a safety perspective, both she and her mom did not want to be on a DMT that was associated with increased infection risk, which is a common side effect, as you might imagine, for medications that are immunosuppressive, with the additional caveat that she had the benefit of being JC virus seronegative. So that gave us the opportunity to include natalizumab in the options for DMTs.
Thank you. Now, this patient, she's young, just 17 years old at diagnosis. Would you expect your care to be different than that of a newly diagnosed woman, say 10 years older?
Yeah, absolutely. This is something I emphasize a lot when I talk about taking care of pediatric patients as opposed to adult patients. Thinking back in your own life, you might imagine, or if you have young people around you, you might imagine that younger patients face a lot of different challenges compared to adults. They're often still in school, so they may have difficulties with school, with their peers, and a lot harder time accepting the diagnosis. You can imagine they're already struggling more with a lot of issues at that age, with things like self-esteem, with anxiety or depression, and pediatric onset MS can really add to all of that and worsen all of those things. So, in terms of school and cognitive function, patients with POMS are actually much more likely to have cognitive dysfunction at diagnosis, which can manifest as needing extra help in school, even years before they present with the clear MS symptoms, which was the case with this patient who had the individualized education plan 3 or 4 years prior to her formal diagnosis with MS. And actually, in the general population, probably about a third of patients with POMS have cognitive impairment, a third have some degree of mood disturbance or behavioral problems. And not surprisingly, they're often intertwined with each other. So an important part of my care and our care in general as a group for these patients is that we want to support these patients in all aspects of their life. So it's not just about starting them on the right medications, but it's also about connecting them with psychologists or psychiatrists who can help support the patients and their families, as well as getting engagement from their teachers, their school counselors, and their school administrators, so that everyone's on the same page and understanding of what they need to succeed.
Dr. Gray-Roncal, in young patients like this one, are there key areas you'd want to address that we haven't talked about yet?
Yeah, definitely. I think one of the common questions we need to address with a patient like her, which is a young woman of childbearing age, is considerations about pregnancy and family planning. So management of pregnancy in people with MS requires a pretty good analysis of risk versus benefits, as well as shared decision making. So this is a conversation we like to have sooner rather than later. Now, in general, pregnancy does not adversely affect the long-term course of MS. In fact, in the short term, pregnant women generally have a substantial reduction in relapses. However, there is also the sort of the downside of the postpartum period where they can experience that rebound in relapses. Hence, generally experts recommend that women with MS are on a DMT for at least a year before trying to conceive. And then when trying to conceive, have a very close relationship with their provider and try to plan out the best time for pregnancy. In general, injectables are pretty safe in pregnancy. The oral medications are contraindicated. And then there's little data right now in terms of the safety of infusions for pregnancy. So we generally tend to stop those during the conceiving planning process. But overall, the message here is that pregnancy is possible. It is not going to adversely change the course of MS, but the emphasis is that it does require great coordination between the patient and their provider.
And breastfeeding, doctor, that should be part of the same conversation, yes?
Oh, certainly. Yes. So in general, studies have found that breastfeeding is associated with a decreased risk in relapses. And then in general, we know that injectables and some of the MABs also have a low transfer into the breast milk.
Thank you, doctors. Our focus for this first case is to describe why early recognition and diagnosis of POMS can improve outcomes and why the initial evaluation should include assessment of cognitive and mood symptoms. What are the most important points from our discussion you'd want our learners to take back to their practices? Dr. Chen?
Yeah, overall, I think first it's really important that we recognize new neurological symptoms and take them seriously and evaluate them thoroughly and promptly when patients present. As we discussed, POMS tend to be associated with higher degrees of activity and inflammation early on. So extra reason why that early diagnosis is important. And the corollary to that is if they're diagnosed early, we can initiate disease-modifying therapy, especially higher efficacy DMTs early on, and ideally as close to diagnosis as possible. Paired with that it's important to have early evaluation for cognitive and mood symptoms associated with MS or in general, which can lead to coordination and implementation of supportive care and supportive personnel. And overall, important to also overall also important to start the discussion on family planning early in diagnosis so that it's something that you can continue discussing over time and not be surprised by.
Nice summation, Doctor. And we'll return with Dr. Chen and Dr. Gray-Roncal from Johns Hopkins in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to today's eMultipleSclerosis review program, focused on the evidence that informs treatment decisions for pediatric patients. We've been speaking with Dr. Haiwen Chen and Dr. Karla Gray-Roncal, two MS specialists from the Johns Hopkins University School of Medicine, about why early recognition and diagnosis of POMS can improve outcomes and why the initial evaluation should include assessment of cognitive and mood symptoms. Let's turn now to our second learning focus. Describe how the choice of DMT can be patient and/or family-centered, and emphasize the importance of normalizing both our patients and their families' daily lives as much as possible. So if you would please, Dr. Gray-Roncal, take us back to the clinic with another patient scenario.
Certainly. So this is another patient of ours. She's a 15-year-old woman who presented with numbness on the right face. She developed numbness on the right edge of her mouth, but then spread to the inside of her cheek and then to the outside. She was able to chew and swallow without any difficulties, although preferred to chew on the left side to avoid biting the tongue on the inside of her cheek. Now, she had been following up in the outpatient setting with plans to obtain imaging pretty soon. However, the morning of presentation, she developed dizziness and went to the ED. MRI in the ED revealed multifocal areas of T2 flare hyperintensities in the supratentorial brain, juxtacortical, and periventricular without any enhancement, as well as one T2 flare hyperintense lesion with corresponding enhancement on the right middle cerebellar peduncle. Now, she underwent an lumbar puncture, and she had oligoclonal bands in the CSF, and her MOG antibody testing was negative. Of note, her father also has MS and is currently treated with dimethyl fumarate. Now, the patient was started on diroximel fumarate as a disease-modifying therapy.
Thank you, Doctor. Now, Dr. Chen, are you confident that this 15-year-old's diagnosis of MS is accurate?
Yeah, absolutely. Her clinical picture is pretty typical. She had the subacute onset of numbness that lasted a few weeks. Then she developed this new onset dizziness, overall suggestive of a new presentation or a presentation of an acquired demyelinating syndrome. She meets the McDonald criteria that we discussed earlier for multiple sclerosis, one with the presence of non-enhancing and enhancing lesions at the same time point of imaging, indicating that some of the lesions are older and some are more acute or newer. This fulfills the criteria of the dissemination in time. And secondly, the presence of lesions in two different areas of the brain, both in the supratentorial and then the one in the cerebellum as well, all also fulfilling the requirement of the dissemination in space. The presence or positivity of oligoclonal bands in her CSF likewise actually also fulfills or could fulfill the dissemination in time criteria. Additionally, one of the things we always talk about in that criteria is exclusions of better diagnosis, which was why having the MOG antibody testing come back as negative is also important to make sure that we don't have another or alternative explanation for her symptoms and presentation.
Dr. Gray-Roncal, why was diroximel fumarate chosen as the DMT for this patient?
Yeah, so after a thorough discussion regarding the various DMT options, as well as the differences in terms of mode of administration, such as injectables, orals, infusions, the patient expressed a very strong preference for an oral medication. Now, as a family, they were all familiar with fumarate since that's what the dad had been taking. And so they felt very comfortable with that type of medication. And that's one of the key points here as well, is that it's important to highlight that in this population of patients, the management of MS at home is a family affair. And honestly, the best medicine for the patient is the one that she will take.
That is an excellent point to remember. Dr. Chen, when a child is diagnosed with POMS, it's only natural for the parent to be concerned about the likelihood of their other children getting MS. How do you counsel them about that?
Yeah, that's a very common question, particularly asked by parents, particularly when they have more than one child, when one of their children is given a POMS diagnosis. And of course, for this family and this patient in particular, her father also has MS. And so what we share with families is that the risk of getting MS in the general population, meaning anyone walking off the street, is 1 in 333, about 0.3%. If there is a first-degree relative, meaning a parent or a sibling with MS, the risk for that individual increases to about 2 to 3%. So, noticeably about tenfold higher. That, of course, still means that 97 to 98% of the time that you're not going to have MS. So it's still a relatively minor risk. If that direct relative is an identical twin, the risk does go up to 20%, which is also about the risk of getting MS if both parents have MS. Overall, the message here is that even though the chances of a direct relative, excluding non-identical twins or both parents, having MS are higher, the relative risk is still relatively low. And so we don't want people walking around with that fear hanging over their heads.
Excellent clarification, Doctor. That's going to put a lot of parents and a lot of siblings at ease. Last question on this patient, Dr. Gray-Roncal. Limitations on what activities children with POMS should be allowed to do. What do you advise parents?
Very important question as well. Parents often ask this question as they worry that exercise and activities will make the condition worse. So the simple answer is no. No limitations. Actually, we often counsel our young patients and their parents that the goal for the management of MS is that the MS is way in the background of their lives as much as possible. Hence, we're very proactive in terms of symptoms that can be addressed and careful in choosing the correct DMT for that particular patient in order to prevent relapses. We also explain that sometimes things like infections or heat can bring back some old symptoms. So this is a conversation that we often have with families as they worry, again, like I said, that exercise, for example, can worsen the MS. We try to emphasize that the transient return of old symptoms is from a prior injury and not from something new. Hence, we encourage exercise. We encourage patients enjoying all other aspects of their childhood, including pursuing their dreams.
Thank you, doctors. Our key focus for this part of our discussion is to describe how the choice of DMT can be patient and/or family-centered and emphasize the importance of normalizing our patients and their families' daily lives as much as possible. What are the key things our listeners need to know, Dr. Gray-Roncal?
Yes. So evidence to support diagnosis of POMS, including ruling out potential mimickers, is essential. Choosing the correct DMT is a joint decision between the patient, patient's family, and the provider. And then, although the risk of getting MS when a direct relative has MS is higher, this number is still low at 2 to 3%. Pediatric patients should be encouraged to continue to pursue their normal activities with no limitations from an MS perspective.
From the Johns Hopkins University School of Medicine, Dr. Haiwen Chen and Dr. Karla Gray-Roncal, thank you both for sharing your knowledge and expertise in today's eMultiple Sclerosis Review program.
Thank you so much for having us. It's been a real pleasure.
We appreciate the invitation.
For eMultiple Sclerosis Review, I'm Bob Busker.